Okay, well, I'd like to welcome everybody. This is our fifth and final lecture in the Beyond the Basics series for Coastal Hospice, and today we want to talk about thanatology. Just sort of look at all the things we've talked about in the last four lectures, but kind of from a higher altitude. This is thought it'd be fun to start with an archaeological quiz. And I don't know if anybody recognizes this.
This would be a mosaic that you walked over in Italy.
Yeah, actually, this is from Pompeii, and the H-A-V-E, the A-V-E is Ave, as in Ave Maria, Hail Mary, so Ave means hail or welcome or hello, and H stands for hospice, H-O-S-P-E-S, which in Latin means guest. So basically this says welcome guest, and this mosaic was at the entrance to a very lovely several thousand-year-old Roman home in Pompeii. And in the Roman tradition, a guest in your home was considered sacred. So I thought that was nice, and I thought that's a nice hospice slide. What I want to do first is to look at the various forms of therapy, conventional medical therapy, palliative care, and hospice care, how they best integrate into the care plan of our patients, and then continue to look at what the various barriers are to this optimal care. Proceed to look at the various patterns of decline in chronic illness. We really want to kind of expand our knowledge of chronic illness over this next hour. Then look at how we make a diagnosis of dying, which is something I think we don't do very well in this society, and then finally look at the various stages of the dying process. And so if we look at this as a timeline, 90% of us are going to die of chronic illness, and this is the point when that chronic illness is made. Patients still benefit from conventional medical treatment, but as time progresses, the benefit from that treatment becomes less and less, and palliative care, focusing on symptom management, becomes a greater and greater part of someone's treatment, until finally there's a point reached where conventional medical care no longer helps the patient at all. It becomes futile. And so at that point, the patient's care should be 100% palliative, and that's the definition of hospice. So that's the distinction between conventional medical care, palliative care, and hospice care. Question that I've asked myself many times during my career is, how are my patients going to die? And I think when I first considered that question when I was a medical student, the question offended me. And it offended me because I thought, I'm here to be a healer, and how can it be, how dare you talk about my patients dying? The first day of medical school, we read a prayer for the physician, which was written by this gentleman. Anybody recognize him? This was an ancient physician, Maimonides, also a famous philosopher as well as physician. And in his prayer for the physician, he referred to the physician as, in Hebrew, Rofe HaCholim, the healer of the sick. And so if you're going to heal the sick, then how can you talk about patients dying? Well, funny thing happened after that. I went into medical practice, and as years went by, I cured my share of cancer patients, but as I followed those patients that I cured over the years, they started to die. Now, they didn't die of the cancer that I cured them of because they were cured of that cancer, but they died of a second cancer, they died of dementia, they died of heart disease, they died of the things that we all die of. And so I had trouble with this for a while, and then finally I thought of another more ancient physician, at least in mythology. And again, another quiz. Anybody recognize who this is? The clue is the staff with the snake. So this is Aesculapius, the great physician of Greek mythology. And he sought nothing less than ultimate medical knowledge. And he learned that knowledge from the snake. And what he learned was how to bring the dead back to life. And so Aesculapius went around resurrecting the dead, and everybody was so impressed with him. But it came to the attention of Mount Olympus and mighty Zeus And Zeus recognized that no mortal should have that power to bring the dead back to life. So he took one of his famous thunderbolts, as you see here, and he hurled it and he struck Aesculapius dead. And so that story, I think, helps remind us about the limits of our medical skills. Well, this is an image of Thomas Cole. And Thomas Cole was a famous 19th century American artist. He was known for his landscape art. And some of his art is allegorical. And probably the most famous is a series of four paintings called The Voyages of Life. And you can view these, the originals, at the National Gallery in Washington. If you haven't, next time you're in the nation's capital, I encourage you to go look at them. And so this is the first of those four, and we'll look at all four over the course of the lecture. Well, what do people die of in America? Still, heart disease is number one. Almost 30% of people die of heart disease. Cancer follows a close second at 23%. 7% die of stroke. 5% die of chronic lung disease. Trauma is 4%. Diabetes, 3%. Well, when we have our patients who are dying, what is it that they expect of us? Their first priority is that they don't suffer. They want to die with dignity. They want to have their personal affairs in order. They want to be at home with their families. And they want to be at peace, both existentially and spiritually. And also tied in with having their affairs in order, so they don't want to feel that they're a burden to their family. Well, where do people die in America? We said people want to die at home, but actually 50% die in hospitals, 30% die in nursing homes, and only 20% die at home. So we're not doing a very good job in terms of meeting their needs of where they want to pass away. One of the things we're really good at is prolonging the dying process. And I've sort of coined my own term, technophilia. We love technology. I blame John Kennedy. Ever since he talked about sending a man to the moon, we just became enraptured with technology, and we thought technology could solve all of our ills. But by putting in feeding tubes, dialysis, mechanical ventilators, pacemakers, and performing CPR, when we do those procedures appropriately, we can help cure people and help prolong life. When we do them inappropriately, all we're doing is prolonging the dying process. And in fact, there is no ethical or moral distinction between not instituting futile treatments and when you recognize that they're futile, subsequently withdrawing them. We're talking about just one of these interventions, and that's cardiopulmonary resuscitation. The national organization that teaches how to do CPR also keeps statistics on CPR outcomes, and so I think it's important to see the data. And if you look at a very specific data set, and that's those people who have an arrest in the hospital, which is witnessed, and we look as a goal of CPR as being discharged from the hospital alive. Now, discharge from the hospital alive may mean that you're well and you walk out the front door. Discharge from the hospital alive might mean that you are in a chronic vegetative state with a feeding tube and transferred to a long-term care facility. So, I mean, the quality of life is very variable, but that's the data we're going to look at. Across the board, all patients, all diagnoses, 15% are discharged from the hospital alive. If the patient has chronic renal failure and is on dialysis, only 2% are discharged alive. If the patients have metastatic cancer, anoxic encephalopathy, they've had a stroke with a neurologic deficit, or they have advanced organ failure, the probability is zero. It is just, in the United States, since we've started keeping statistics, it just hasn't happened. Now, that doesn't mean they might not survive the arrest, but they're not going to survive their hospitalization. Some hospitals like to grease their statistics, and you got to look at what they're listing at. And if they're publishing survival statistics from CPR, then they're just talking about at the end of the arrest were they still alive. And so that's a very different number. It's important to recognize what patients' rights are and the various advance directives. Patients have absolute negative rights. If a patient has capacity for decision making, they have the right to refuse any treatment, even if that treatment is life-saving, and even if their physicians strongly feel they should have it. They do not have absolute positive rights. Patients don't have the right to demand fetal therapy. And this is supported in Maryland law. Ways that patients express their desires, the ideal way is if they're awake and have capacity for decision making, they can make their own decisions. They may have living wills written, and these are very variable in terms of what they say. Most living wills deal with being put on ventilators and deal with medical administered hydration and nutrition. They often don't deal with a lot of other things we do at end of life, such as hemodialysis. So the problem with living wills is it's hard to anticipate all the various possibilities at end of life. The ideal advance directive is to designate a healthcare agent and to have a document called a power of attorney for medical decision making. This doesn't have to be your next of kin. It doesn't even have to be a blood relative. It should be that person who understands what your wishes are and you feel is most likely to represent your wishes. It could be your attorney. We had one patient not too long ago where it was his mailman or her mailman. So that's the ideal. If you only have to have one, that's the ideal advance directive to have. If there is no living will, no power of attorney established, then we go to surrogate decision makers. And this is defined in Maryland law, and it goes through a series of relatives, spouse, parents, children, what have you. A problem that comes up frequently is that we have multiple surrogate decision makers of the same class. And so according to Maryland law, usually adult children. And so there's 4 children, 3 of which are intelligent, rational, kind people, and the 4th is a psychopath. And what to do when they're not all on the same page. And what to do is defined by the Maryland Healthcare Decisions Act. And it says in that situation, we are required to have the Hospital Ethics Committee, which is a patient care advisory committee, meet. So by law, that committee must meet when surrogates of same class can't decide. And the decisions of that committee gives the attending physician protection from litigation for failure to obtain consent as long as he follows the guidelines recommended by the committee. This is the second in Thomas Cole's series. And here you can see the young man, the angel has left the young man, and he is confident, and he's got his firm hand on the tiller, and the water appears smooth, the path appears straight, and there looks like there's this beautiful future up ahead. I call this slide to the attention of young people in the room, Karen, because I think this is what happens is when you look, this beautiful future is diaphanous, and this is kind of pie in the sky, and there's a sharp right turn up ahead, and there's white water you can see hidden by the trees, which this young man is completely oblivious to. Well, how do we make a diagnosis of dying? Probably the most important thing that we can transmit to other physicians, to other healthcare workers, and to families, and we do a terrible job of making a diagnosis of dying. And we tend to think of dying as somebody's on their deathbed, they're taking their last gasp, but in fact the dying process begins many, many months before that moment. We're going to define dying as the patient has a life-limiting illness and they are declining despite best medical treatment, or they are having increasing medical treatment without improving their quality of life, or they have decided they want no further measures to reverse their current problems. In Yiddish, that's called genug, which means enough already. So when the patient says enough already, then they are dying. The Medicare law stipulates a prognosis of 6 months or less if the disease follows its usual course to be eligible for the hospice Medicare benefit. Determination of prognosis is a complex process, but I wanted to just highlight a few simple situations in which the patient would clearly have generally a less than 6 months prognosis. If the patient has metastatic cancer, which means the cancer has spread from the primary site to other organs, and there's no further meaningful antineoplastic therapy available, we would expect a prognosis less than 6 months. If the patient has end-stage cardiac or pulmonary disease, and they are dystmic at rest despite maximal medical therapy, they would qualify. If the patient has a neurodegenerative disease like Alzheimer's disease, they are progressively losing weight, they are having swallowing difficulties, we would also expect a less than 6 month prognosis. So some common situations. Well, physicians find it very hard to transition from curative to palliative, and so I'm going to now kind of explore some of the barriers to hospice care. And why is that so? Well, if your goal is to be a healer and your patient dies, then that's a therapeutic failure. I had a speaker from Hopkins say yesterday at a meeting that Johns Hopkins has yet to ever have a patient die, which is an interesting way of looking at it. Docs, like myself, we're always afraid we miss something. You know, so you're always challenging, which is a good thought process. You're always saying, could I have done better? What have I missed? But there's a point in which there is nothing left that you might have missed. But we're afraid that that might happen. We're afraid and uncomfortable dealing with end-of-life issues. We view healthcare paternalistically. We think it's our job to tell patients and family what they should do, and it's their job to do what they're told, and we know best. We're afraid we're going to get sued, and we're just too bloody busy to have time to sit down and talk with the people. So I think these are the physician's barriers to making the transition to palliative. Well, something I learned from the social workers is how to give bad news. And everybody in this room, I think, knows how to do this, but I put this slide up mainly for my fellow docs. But I think there's 5 steps, and you can't violate any of them. Rule number 1 is you have to sit down. If you stand at the doorway leaning up against it, ready to run, by the way, you're going to die, and then you run away and close the door, that just doesn't work. You absolutely have to sit down. And as you can see, the example in this photograph, this gentleman is doing a lot of nonverbals. He is leaning towards the patient, he's making eye contact, and he has decided to touch him as well. How many of those you feel appropriate, you know, you have to judge from the circumstances. Touching patients, a lot of Americans have a bubble around them and don't like people coming into their space. People from other cultures won't talk to each other unless they're touching each other. If you've ever seen a street scene from Spain or Mexico, people are standing there talking to each other, and they've got their fingers on their collars and their clothes of each other, just sort of rubbing the clothes. And that's just considered normal, where Americans, we'd just be backing up when somebody does that. So you have to know what's culturally appropriate, but absolutely you got to sit down. Second thing is you need to fire a warning shot. You need to let the patient and the family know that you're going to talk about something serious. I've reviewed your scans and they're not very good. I have some bad news for you today. Just a little time to let them catch their breath and realize something bad is coming. Third thing is to tell the truth. Don't use euphemisms. As simply and directly and as compassionately tell people what the facts are in the case. And at this point, what do you think the patient's biggest fear is? Most people say that they're going to die. But actually, that's not their biggest fear. Their biggest fear at this moment in the conversation is that you're going to abandon them. And so the important thing to follow that up immediately with what the new care plan is going to be. Here's a prescription for a narcotic to try to deal with your pain. I think it's an appropriate time to have you go see hospice, because the nurses will come out to your house and they're going to help, and they're going to help me take care of your symptoms, and we're going to make that referral, and I'm going to make you an appointment to come back and see me in 2 weeks, so that the patient understands that you're not going to abandon them and you're still going to be with them. And the final and probably the most important step is, after you've said these things, is to shut up. And sometimes that becomes uncomfortable because there's this long pause when nothing is said, but that can be very therapeutic as well, and then give them an opportunity to then bring the conversation back to you. Okay, well, we've talked about barriers from physicians. Patients and families present some barriers to care as well. And the first one is that they expect miracles. It is uncomfortable to recognize how high a pedestal that patients and families put their doctors on. And you may have, if you've been treating a cancer patient, got 2 or 3 remissions, and even though they understand that the cancer is incurable, they don't understand why you can't keep pulling rabbits out of the hat. And when you tell them that there's no more treatment, they don't understand, because they think you ought to be able to continue to do miracles. Patients and families are afraid that they're giving up, and that's a sign of weakness, transitioning from conventional to hospice care, and they don't want to be weak. They can't accept the facts that you presented to them, and so they want to deny them. They're guilty. They're afraid that they're getting worse because they've done something wrong in their life. And always remember the mantra of the matador, which is that the appearance of the bull changes when you enter the ring. So it's real easy for us to sit back and think what patients and families should be making decisions, but we're not staring those horns in the face. And actually that horn is not in the face. Well, the whole medical healthcare system provides barriers to optimal care as well. And the first one is the Field of Dreams line. Field of Dreams is a wonderful movie, and it's really about the layers of the subconscious. But the line, and it has nothing to do with baseball, despite what you may think, but the line that everybody remembers is, if you build it, they will come. So if we build a new wing of a hospital and put another 50 beds, whether the patients need to go in those beds or not, we're going to fill them. If a drug company comes out with a new medication, whether it's appropriate or not, it's going to get used widely. If we come out with a new medical device, whether appropriate or not, it's going to get used widely. So the system just encourages more and more treatment regardless of its benefit. And you combine that with how inadequate the resources are for end-of-life care. You know, walk through a hospital and then walk through a hospice, and you're struck with the difference in funding of those two institutions. And so the resources to care for people at end of life is so inadequate that there's pressures to take feudal therapy. And so there's all these financial pressures that force aggressive care. President Eisenhower coined this term military-industrial complex when he was leaving office in the late 1950s. And I'm trying to remember the name of the Republican in the Republican primaries in this election, Ron Paul. He coined this term medical-industrial complex. And in the same sense of the military-industrial complex, we have this medical-industrial complex. Industry and healthcare financially benefit from each other and feed on each other, and rather than doing good science, we end up building things so that people will come whether they need them or not. So there's all these forces in the system itself that work against us. This is a Dilbert slide from our daily fish wrapper a few months ago. I don't find this slide funny at all, but Dilbert really hits on the way the public sees business and healthcare, and this is really true. And having been in private practice for years, the good-looking drug reps every day are sitting in the waiting room trying to pressure us to use their products. I don't know how Dilbert understands all these things, but he really does. Well, this is sort of where I feel I am in my life, the third of the Thomas Cole paintings, and like to look at how patients decline from various chronic illnesses and what those patterns are. 10% of people die of sudden death, and these graphs plot time on the x-axis against performance status on the y-axis. And so people that die suddenly have a normal performance status and suddenly just, drop off. My favorite is the story of Picasso, who in his mid-90s was still very productive. He was creating new and interesting art. He had a bunch of friends over one night. They had a lot of good conversations. They had a lot of wine and a lot of good food. And at least according to the legend, two of the young ladies spent the night with him. And the next morning they discovered that he had passed away in his sleep. And so that's my goal, but we'll see. Pattern of decline in cancer is somewhat different, often described as falling off a cliff. And cancer patients actually maintain a surprisingly good performance status for a long time, and then when they decline very rapidly. And so there's a lot of people up here just before the shoulder of the curve that are really having trouble accepting that they're dying. Their scans look awful, but they feel pretty good and they're still pretty functional. And so there's a discrepancy between how they look on paper and how they look in person, and that is often hard for patients and families to reconcile. Cardiopulmonary follows a very different pattern. A patient in congestive heart failure or chronic lung disease manifests a lot of exacerbations and remissions. And this also causes a lot of problems with patients and families because what they remember is going from a low point back uphill. But if you look at the crest of each one of these, it's lower than the one before. So the pattern is still downhill, but manifest with a lot of exacerbations and remissions. And you have to point out to people, you've had 4 hospitalizations in the last 6 months. Your time at home is less and less between each hospitalization. And think what you could do 6 months ago and what you can do now, and realize that even though you're better than you were a week ago, you're not better than you were 2 or 3 months ago. And so this is a pretty typical pattern for those diseases. Neurodegenerative diseases like Alzheimer's disease or Parkinson's disease follow again, a very different pattern. They live a long time at a very, very poor performance status. And so they have years and years and years of very, very gradual decline, but doing very poorly throughout this time. I think the average life expectancy from diagnosis to death in Alzheimer's disease is like 9 years. And it's just a terrible, slow, very lingering death. Well, once we've made the diagnosis of dying, common question is, how long have I got, doc? And obviously none of us know how long any of us are going to live. And it's appropriate to shuffle a little bit and say, well, none of us know, and we can't be sure, but we can make an intelligent guess. And in hospice, we use this book called this little booklet called Gone From My Sight. The hospice nurses call it the Little Blue Book, and it defines 3 phases of the dying process: weeks to months, days to weeks, and hours to days. And the answer I always give is in one of those 3 terms, so that I'm using exactly the same language that the booklet uses, so the family can look through the booklet and be on the same page. And so the weeks to months period, the first sign of the early dying process is they begin to withdraw from the outside world. If it's a patient that I've cared for a long time, I've gotten to know them personally, and I know some of the things that they're passionate about. Maybe it's the Baltimore Orioles, maybe it's their grandchildren, but there's usually things they always want to talk about at their visits. And when they start to lose interest in those things that they've always been passionate about, they're starting to back away from this world, and that's very typically the first sign of the early dying process. They often sleep more hours of the day. Their appetite goes down and they start taking less food. And so these are the typical findings in the early dying process. The middle stage of the dying process, the days to weeks, we start to see occasional disorientation. Some of this disorientation may be agitation and delirium, where they're seeing things that are scaring them, but very typically some of this disorientation involves them having conversations with people who have already died, that were friends and family members, and the disorientation often involves taking trips. And our chaplains refer to this often as journey language, and that's a very typical of the middle stage of the dying process. Patients start to have fluctuating vital signs. They may have fever. They may have periods of varying respirations. They may stop breathing for short periods of time. They may become cold and clammy and sweaty intermittently. And sometimes, and it's completely unscientific, and I don't have a clue how to explain it, but I've seen it enough times that I believe it, there is this surge of energy that happens a few days before someone dies. They were minimally responsive and disoriented. Now they're perfectly clear and lucid. They wake up, they want to get in the car, they want to visit with all their families, they want their meatloaf and mashed potatoes, that they weren't eating anything for a long time. This can often be a great gift to patients and families, but there's a danger here as well, and the danger is that it's perceived as a miracle, and they think they're cured. And so we do advise patients and families to expect this, particularly families, and it also is described in the Little Blue Book. So, but even though they've read about it and we tell them about it, very often it's still seen as a miracle. Well, the final is the hours to days, and this is a fairly precise term in hospice, which is called actively dying. And we need three things to describe someone who's actively dying. They need to have profound weakness, a profound decrease in mental status, and cool extremities. And when all three of these are present, generally the patient is going to pass away within the next 1 to 2 days. Now, does every patient have all three of these findings in the last 1 to 2 days of their life? No. To quote my Southern former partner, some people just up and die. You know, they're up and talking to you and look great, and 2 minutes later they pass away. Dying is hard work, and there are things that people need to accomplish before they die. Most of these are things that we should all deal with while we're in good health, so that we don't have to try to deal with them at end of life. A lot of the suffering at end of life comes from people not completing these tasks of the dying. The first is, please forgive me. Acts of contrition. Forgiveness requires you to say it was your fault, to say you're sorry, and to see what you can do to make it right. An act of contrition is also a great way to resolve a conflict. If it's not a big deal, why not? And even though you really think you were in the right, why not just concede? It's amazing, and you confuse people, and then you have them in your debt, and you can call that shit up when you need it. So contrition is important, a task of the dying. The second is, I forgive you, acts of grace. It's important to bury the hatchet with your family and your friends. Third is to remember to say I love you, and love has no conditions. And then finally is to say goodbye. This is the last of the Thomas Cole paintings. This little boat that we've been following throughout this lecture is pretty badly battered. If you notice that beautiful bowsprit, the rudder and the tiller are all broken off and lost. But the sea is finally calm, and our plucky voyager is at peace. And that is the end of my talk.
Do it over.
Any questions?
That was wonderful.
Thank you.
Excellent.
That was
Excellent.
wonderful. I loved it.